I'd just like to spend a minute introducing myself and allowing Dr. Correa to introduce himself as well. I'm a clinical specialist manager at Sword Health. I joined Sword about 2 years ago, 2.5 years even, from clinical practice where I worked with people in brick and mortar settings, helping them address their pain. I worked in Colorado and I also worked abroad in Ireland. And the thing that brought me to Sword was really the determination and goal of finding more people to help and being able to scale our care to people who didn't have access to it. And hopefully today we'll be able to talk about the impacts we can have with those people. Fernando?
And hello, everyone. It's a pleasure to be with you today. I am a neurologist by background with a PhD in digital medicine, and I'm part of the founding team at Sword. So I've been at Sword for 7 years now, and building a company that we really believe in, and starting off with just a snippet of a personal story. My mother was recently submitted to a total hip replacement 5 days ago, 6 days ago now, and she's currently going through our program. So if you ask me, this is the solution that we want for our loved ones and the solution that we believe in. And you're about to see why in a minute through this presentation. And so now I will hand this off to Megan again to kick us off in today's talk.
Thanks, and thanks for sharing that story of your mom. We saw a picture of her totally crushing her exercises yesterday, and so hopefully she has a speedy recovery. And really, that type of story is what we want to ground ourselves in today. This is why SWORD exists. We aim to free 2 billion people from pain. And Darlene, who will take through this journey today, is one of the people we really are trying to help. This is Darlene. Darlene is like a lot of the members we see at Sword. She works full time. She has a family, including a couple little kiddos. She loves spending time with them and her husband, but also likes getting after it on the pickleball court and getting into her garden. As I mentioned in the intro, I'm a physical therapist, and this slide is really why I love my job. When I get on a video call with a member, I get to hear all about their lives and what they value, and then help them come up with a plan to do all the things they care about and the things that they're not able to do today because of pain. So Darlene also suffers from pain. She is experiencing chronic pelvic pain, and this is why she came to us. The pain started after the birth of her first child, and it didn't go away. She had 2 C-sections along the way, and those are both major surgeries. The pain's gotten so bad that she's actually stopped playing paddleball, and she doesn't get to garden as much anymore. It's starting to affect her work. It's forcing her to take sick days, something she never did before. She's a teacher, and in the classroom, she's struggling to keep up with her students. She finds herself giving assignments that she can oversee from her desk, rather than the type of work that she and her students really enjoy and learn from, which involves her moving around the classroom. At home, she's feeling irritable, and she's experiencing painful intercourse, which is weighing on her marriage. Her therapist even suggested putting her on medication for depression, and she finds herself waking up during the night, unable to fall back to sleep. Darlene's experience is sadly more common than you may know. I'm going to ask Fernando to walk through a couple slides. As he does that, think about how many Darlenes there may be in your population.
And as you think about how many Darlenes there may be, you need to consider that there are a lot more than you probably think. 1 in 4 women in the US suffer from moderate to severe pelvic floor disorders, and 1 in 3 suffer from urinary incontinence. Now, urinary incontinence is not normal. Moreover, 60% of postpartum women have a separation of the abdominal muscles, and more than 30% of that separation doesn't resolve spontaneously and lingers on for 6 to 12 months after giving birth. To further compound the issue, 74% of women have clinically significant symptoms of prolapse, either vaginal prolapse, rectal prolapse, or bladder prolapse. And a lot of women, like Darlene, suffer from chronic pelvic pain and experience reduced productivity because of that. They also experience a lot more direct medical costs than other women who don't suffer from pelvic health conditions. Now, what can we do about this? So if we drill down into what evidence-based pelvic floor therapy looks like, It actually turns out that by helping people to learn how to strengthen and lengthen and contract and relax their pelvic floor muscles, you can impact a lot of these conditions. You can help with pelvic floor dysfunction and pain. You can, by helping with that, improve their sexual health. You can improve bowel and bladder disorders by reducing or impacting urinary and fecal incontinence, and by helping with prolapse of pelvic organs. You can also help women go through pregnancy with less pain. Low back pain is widely pervasive during pregnancy and also during postpartum, where it is further compounded by urinary incontinence and by thoracic pain due to breastfeeding. We can also help with perimenopause symptoms, and this is all on the physical aspects of things. But this has a huge impact on mental health because in the majority of the cases, just as you've seen with Darlene, there is comorbidity with sleep issues and with mental health disorders. Darlene's physician suggested that she started taking depression pills. And what we see is that 63% of people suffering from chronic pelvic pain also have comorbid depression and anxiety. So we also need to tackle this as an integral part of the programs. Otherwise, we're missing a huge opportunity. Not only we need to address the root cause of things, which is dysfunction in pelvic floor muscles, but we also need to compound the program with tools aiming at tackling depression and anxiety. And we also need to deconstruct myths around what's normal and what's not normal around pelvic health. It's a taboo issue in many cases, and it's definitely an issue where a lot of misinformation exists. Again, just a snippet of information, urinary incontinence is not normal and can be and should be treated.
Thanks, Fernando. I feel like we need to say it louder for the people in the back. It's a really important message there. And just like so many people who are experiencing pain, Darlene has never gotten an answer for why she's suffering and that there's even something she can do about it, even though we know there's a clear path to recovery for her. She feels like her body's failing her, and because of that, she's failing everyone she loves. She's failing her husband, her kids, her students, her friends, and even herself. So what's she to do? She's not alone in this experience. And the problem is that our system isn't really structured in a way that makes it easy for Darlene to get answers. The end result is that something like pelvic health therapy that Fernando talked about, something that can actually make a big difference and is relatively inexpensive, isn't even presented to Darlene as an option. And it's really important to realize that Darlene's medical claims, extra PCP visits, visits with her therapist, potentially medication for depression, drugs from her gynecologist for pain, are all connected to one issue, which is her pain. And again, that is what brings us here today. Our mission is to free 2 billion people from pain, and that pain is just the tip of the iceberg. When we see somebody struggling with pain, that might be what we see and what they actually identify themselves. But below the surface, so many aspects of their lives are really being affected. From an intervention point of view, we want to identify and treat the people when they're feeling that pain before it causes all these other things to happen, before they have expensive surgeries or lose productivities or call in sick to work, before their mental health suffers and their quality of life falters. We want to intervene before things like minor musculoskeletal and pelvic health issues become chronic and much more expensive problems. Little things can become big things and cause people like Darlene to stop doing the things that matter to them. So solving pain is really solving well-being. By addressing the pain, we're addressing a whole host of issues related to a person's overall life. Just to make sure that this is super clear, living with pain can affect all areas of well-being, and this is really a bidirectional relationship. Pain can affect your physical activity levels, your mood and appetite, your financial health, your sleep, the relationships of people in your life, your stress, your ability to participate in hobbies and leisure, your productivity at work. And all of those things, again, will impact your pain as well. And I'd love for Fernando to comment on the connection with physical and mental health a bit more.
Sure, with pleasure. I mean, there is a very, very well documented bidirectional relationship between pain and mental health. Uh, on the one end, people with chronic pain, uh, almost 80% of them screen positive for moderate to severe mental health condition. And importantly, 40% of these people had never received a diagnosis for a mental health condition. So in all likelihood, there is a significant contribute of the chronic pain that they're feeling to their mental health status. And what we need to do is we need to recognize this relationship and address mental health issues at the same time that we are addressing pelvic health and also or MSK health issues. But the direction goes the other way also, and it forms a vicious circle that leads people down a downward spiral. So pain promotes depression, which makes it harder to treat pain, which then leads to more depression. And there's actual evidence for this. Mental health comorbidity is a risk factor for acute pain to become chronic and is also related to a greater impact for the same level of pain in the ability to conduct activities of the daily life. So there you go. Pain feeds depression, depression feeds pain. So how can we escape this? And we are about to see during this webinar how we can tackle this and how we can escape this downward spiral. But mental health issues are not all that we encounter. So members come to us in all shapes and sizes, and beyond the condition that they have a whole host of other things. Mental health comorbidities. 8 to 10% of our members screen positive for a moderate to severe anxiety or depression condition. They also report significant sleep disturbance. About 38% of our members report some form of sleep disturbance at baseline. And they all come with other issues, namely obesity. There is an epidemic, unfortunately, and 37.6 of our members are obese at baseline. And this just reflects how people are. And it just means that we have to deal with people that come to us with all of their problems, not only the immediate problem that they seek help for, but also actually tackling what's adjacent can be the key to actually produce long-standing outcomes, as we'll see. Now, how can we deliver holistic care while focusing primarily on pelvic and MSK health? When you look at it this way, there are so many interconnections between pelvic and MSK health and other healthcare conditions that impacting MSK and pelvic health will certainly help impact the others. A few examples on this slide. 8 in 10 people with chronic pain screen positive for mental health conditions, and 3 out of 8 have never been diagnosed with a mental health condition. You knew this already from the previous slides. What you probably didn't know is that there is a 25% increased risk for cancer in people with back pain. There is also a twofold increased risk for heart disease for people with back pain, and a 5-fold increased prevalence of diabetes in this population in comparison to the general population. And this shows us, and probably this is related with the obesity also. So as you can see, obesity, hypertension, mental health conditions, cardiovascular disease, it all boils down to the same group of conditions that can be impacted by becoming more active, adopting healthier lifestyles, and exercising. And it's about what we do. It's what we do. We deliver exercise interventions, behavioral change, and we do this in a way that is engaging and that leads people to actually go through our programs. So back to Megan and Darlene's story.
Thank you. Yeah, so addressing MSK pain and pelvic pain can really lead to health improvements across the whole population. And so we also need to take a holistic approach. Darlene's pain journey and the associated struggles actually really reminded me of a person I worked with who's a real human being. She was working at a company we partner with and nearing retirement. And when we first met, she said she wasn't even that excited about retiring anymore because her knee was getting in the way of her doing all the things that she'd been optimistic about doing during retirement. She'd been working her whole life and she finally was going to have enough time to do the things she loved. Gardening, actually, like Darlene, but also spending a lot of time quilting, which requires quite a bit of kneeling. She just wasn't confident her body would hold up for it. Luckily, we met in her final months of employment and we were able to work together to get her strong, mobile, and pain-free. I was really delighted a couple months later when she was near past her working time. She was in retirement and she sent me an email with some photos of quilts she made for her family for Christmas and shared that she was still doing really, really well. So she was happy, she was active, she was doing something that was meaningful for her, and that meant a lot to me. But what probably meant a lot to her employer is that she was able to cancel the surgery she'd planned for right before she lost her health insurance to have a knee replacement. And instead of having that knee replacement, did the Sword Health program and was able to feel good without having a costly and time-consuming surgery. So how do we help that member and how are we going to help Darlene? It's really based on 3 pillars of care. We have a personalized, appropriately dosed exercise program for each member. We educate that member on their condition, pain science, and habits that can really make a difference. We help coach them through behavioral change using things like cognitive behavioral therapy tools and principles, and even taking advantage of something called the Hawthorne effect, which is where we see somebody or somebody knows they're being watched and they change their behavior. So having a physical therapist on their team helps them actually start committing to doing things like exercising regularly that'll make them feel better. And this program really starts with that doctor of physical therapy who's there for that member throughout their entire journey, giving them those 3 pillars and helping provide support along the way. As an aside, if you're not familiar with doctors of physical therapy, we require our clinicians to have this DPT degree because it's the highest degree you can get for physical therapy. It requires you to go to college and do an additional graduate school program, so 6 to 7 years of post-secondary education, as well as at least 1,200 hours of supervised clinical experience. We know that members who come to SWORD and who have pain in general often feel pain in a place that's different from the pain generator. So they might present with low back pain and we discover that it's actually due to a pelvic health condition, or they present with elbow pain that we track back to a neck condition. And that doctor of physical therapy can really figure out the root cause to get the person on the appropriate program. And at SWORD, we really value that one-to-one contact between the doctor of physical therapy and the member, through video calls, chat messaging, and support throughout the entire program to help make sure that we're giving them the right level of care and every member is able to progress as we'd expect. What does this look like for members going through SWORD and our pelvic program? So whether we're doing digital physical therapy for musculoskeletal disorders or for pelvic health disorders, you'll have that doctor of physical therapy. You're going to have a fully tailored experience where your physical therapist adjusts your program to you, where you are in your pain journey. And you'll also have some technology to support you along the way. The technology is going to give you biofeedback, so it's going to help you understand when you're doing things correctly or when you can change the way you're performing a movement, and help give you real-time education about how your body works. Whether we're caring for people with a pelvic disorder like Darlene or somebody who has a knee pain like the patient or member I mentioned a few moments ago, we know that these are the 3 key tools for any program. So just to double down on that, the structure is the same, but for that pelvic program for Bloom, we do use an intravaginal device to provide that feedback. And that's a way to give people the crucial feedback they need to learn to retrain their pelvic floor muscles. And a real differentiator, because we know that it's really hard to figure out how to work this part of your body. It's often secretive and private and something that's not talked about. And this pod provides you with the feedback you need to properly perform exercises and to gain control over something that can be really life-changing. All right, so now that we have spent some time talking about why Darlene has come to us and shared how we approach caring for somebody like Darlene, let's have Fernanda talk through the outcomes we can expect somebody like Darlene to have and how we expect her physical, mental, and emotional well-being to improve with the program.
Thank you, Megan. Before jumping into the actual outcomes that we have been witnessing on our members, let's first discuss what we measure and how we measure the impact of our programs in the whole person. So at SWORD, everyone is assessed at baseline and then throughout their programs, which allows us to sequentially map how people are improving. Now, besides looking specifically at things which are directly related with physical health, like pain, intent to pursue surgery, and medication intake, we also assess things like anxiety, depression through validated scales. We look at productivity. We also look at fear avoidance beliefs. And then we look at body area specific patient-reported outcome measures, which depending on the scale, they all talk about disability. So they all ask people how difficult it is for them to do certain activities depending on the chosen body area. Darlene, for example, would get the pelvic floor impact questionnaire 7, which is what we use on to map pelvic health, and is one of the ways we measure the impact that we are seeing across our member base. Now, but this is how we measure and what we measure. But the secret sauce for success of any intervention is getting people to actually engage and complete the intervention. Again, the best pill is the pill that the person takes. And they do need to take their exercise pill and their educational pill and their cognitive behavioral therapy pill if we are to be effective. And this only works if we manage to wrap the program in a way that is engaging and that actually delivers value to our members. And this is actually translated into this slide. So we have huge member satisfaction on average, 9.7 out of 10. And our members do complete on average 31 sessions in total. Now, if you compare that with the traditional course of physical therapy of 7 to 10 sessions, then you can see that there is a huge difference. And this is only speaking about people who actually end up engaging and completing their physical therapy program, because unfortunately only 30% of people end up by completing the program, or anywhere between 30 to 50%. And almost 50% of people drop out after just 4 sessions. And it's not that physical therapy doesn't work, it does work, and we very much believe in it. It's just it doesn't fit into people's lives most of the day. People don't have time to go from their houses to an outpatient clinic, wait on the waiting room, have the session, and go back home. And so there is time and transportation issues that get in the way of actually completing sessions. So by delivering an engaging intervention that people can do in the comfort of their home whenever and wherever they can, or on the go, we maximize completion rate, and therefore we have an industry-leading 83% completion rate. And this is really the secret sauce behind the numbers that you are seeing on this slide. So on average, our members are experiencing 62% improvement in pain in comparison to baseline, 60% reduction in the intent of pursuing surgery. We have a lot of examples similar to the one that Megan shared about that member who engaged with SWORD instead of going for a knee replacement. And we can achieve about a 50% reduction in the consumption of painkillers, and not only over-the-counter and prescription meds, but also importantly, opioids, because that is unfortunately one of the epidemics that we see pervasively, unfortunately, and especially in the US. But you've seen 3 stats of things which, although very impactful, how do they translate into the actual lives of people? So what do those outcomes mean? So now to bring this to life, here are three very interesting stats. 80% of our members feel better or a great deal better at the end of our programs. And then if you look at the impact that their condition is having on productivity and on their activities outside work, and if we look at people who are impacted at work and outside work because of their condition, we see a 52% reduction in overall productivity losses. So mixing together absenteeism and presenteeism. And we also see a 53% improvement in their ability to carry out their leisurely activities outside work. So this is impacting real lives, work, and the lives of people outside work. This means taking care of their kids, playing with them, doing household chores, and doing whatever it is that brings them meaning to life over and beyond the important work that they do when they are actually working. So we started off by measuring and looking at the impact that we're having on physical health and how that helps people live their lives. But now I'm drilling down on our impact on mental health. If we look at within our member base, people that screen positive for moderate to severe anxiety or moderate to severe depression, and if we follow them across time, we see that 73% of them stop and no longer screen positive for moderate to severe anxiety by end of program, and 76% of them no longer screen positive for depression. So this is rescuing people that were down the path of a serious mental health condition from going down that path. And we're not presenting this data today, but when we last looked at the mental health outcomes of digital mental health companies and compared them with our impact on mental health on our member base, what we see is that we are on par with mental health companies in terms of how much we can impact mental health. And again, this ties back to what we saw a few slides above, of the very close and bidirectional relationship that physical and mental health have. If we tackle chronic pain effectively, and on top of that, we also add education and cognitive behavioral therapy, we can massively impact their pain issue, but also their mental health condition. So we impact physical health, we impact mental health, we impact the ability that people have to work better and live their lives better. And a part of that is also because we help them sleep better. If we look at people, the 38% of people that have sleep impairment at baseline, 69% of them have at least partial recovery, and 54% reports total recovery in their sleep issues by the end of program. And this is important in two ways. First, or in several ways. First, it helps with their mental health. It helps because they can live their lives better. And actually, sleep deprivation is a risk factor for MSK injury. So we are also reducing the risk of these members to have another MSK issue in the future. So in all of this, how do we stand in terms of achieving long-lasting impact in the other dimensions that our members have? We talked about a 37.6% of our member base being obese. So, and we are not a weight loss company. But can we impact weight? And the answer is yes, we can. And why? Because we get people to adopt healthier, more active lifestyles. We report a 33% increase in physical activity levels across our member base in comparison to baseline. And through getting people to become more active and making healthier lifestyle choices, um, our members on average lose 2.3 pounds towards the end of the program, and our more obese members, so BMI over 40, lose even more than that, on average 9.4 pounds. So we're not saying that we are a dedicated weight loss solution. We are not. We're saying that getting people to become more active and living healthier lifestyles is a tool that can help them control their weight, uh, improve their physical health, and improve their mental health and also their sleep.
Thanks, Fernando. So hopefully that made it a little bit clear how improving physical health can trickle down to all these different aspects of our lives, mental, emotional, our ability to work, our physical body. And that's really just because pain is such a barrier to movement and it stops us from doing things. So let's jump back to Darlene to see what her journey is like. Pain is what we're here to talk about. And pain is not normal, but a lot of times we're kind of socialized or conditioned, particularly as women, to think that pain is just a part of life and that that's something we have to deal with and that there's no way to address it. And this happens because we don't have tools or awareness of the solutions that exist to help us. And that when we do know about them, they potentially can be so out of reach. It can be hard to get to a place to actually get care. Even if Darlene had been offered in-person physical therapy for her pelvic pain, would she have been able to do that between her job and her childcare duties and her social commitments and caring for elderly parents, things like that? Would she have had transportation reliably? Would she have been able to afford the copays? I don't know. It's really a barrier that stopped people to getting care when I worked in the clinic and something that we're really trying to overcome at SWORD. And what is that journey like at SWORD? So whether somebody's coming to SWORD for their musculoskeletal pain or like Darlene, coming to us to help her through her pelvic health disorder using Bloom Powered by SWORD, the journey really begins with becoming aware of a solution for your pain. In Darlene's case, she's fortunate enough to see an email from the school district that employs her. They're offering SWORD and Bloom to all of their employees. A quote in this marketing really speaks to her, and she lets herself hope just for a little bit that maybe somebody can answer her questions and give her some direction. The enrollment process is really simple and asks some questions that we use to track the person throughout the entire program. We want to make sure that they are appropriate and safe for remote care, so there's some red flag screening. But we also go through a lot of the outcome measures that Fernando brought us, talked about in the earlier slide. Things about pain, medication use, surgical intent, how your pain's affecting your function and your ability to work and do your daily activities. We'll kick everything off with the program meeting a physical health specialist. For this, in terms of pelvic care, we do have people who are doctors of physical therapy like me, but also have an additional level of training in our pelvic health specialists. We'll send you the technology that you need to do your program. So Darlene will get the pod that she'll be using to maintain her progress and to do her exercise sessions. And that exercise is really critical. So the doctor of physical therapy is there to provide support, answer questions, educate, and coach. Darlene does her exercise sessions several times per week. Every time she does it, the doctor of physical therapy can review that information and make changes to the program. And sometimes those changes are big and sometimes they're small and sometimes it's just saying good job, but that doctor of physical therapy is there for Darlene the entire way. Education and cognitive behavioral therapy content are really critical to understanding your health and to making changes, so that's there as well. And we expect people to engage in our programs typically somewhere between 8 to 12 weeks. But this is all dependent on the person and what their goals are and what we need to accomplish those goals. So going back to Darlene, after her program, she shares that this is the first time in years I'm waking up without pain. I can do the things I want to do, like play pickleball. I can't wait to get back in my garden again. I've even lost some weight, though that wasn't her goal. We'll see people tell us these stories every day. And as somebody who works with members directly, I get to hear them, but I love to be able to share them more openly as well, because this is why we exist, is to free 2 billion people from pain. And that starts by meeting every person where they are in their pain journey and bringing them the best quality tools to get out of pain. Right. So we have time for some questions and we'd love to hear what's on your mind and answer them.
It appears we have several questions already.
Awesome.
I am going to start addressing some of them, and Megan, you can address the others. So the first question that I have here is, how would virtual care compare to in-person therapy? Well, there are, I'd say, three sides to this question. First is digital and in-person are not competitors. This is not a race to see who's best. There is a space and a place for both in-person and digital care pathways. The pandemic has shown that digital care pathways are now an established way of managing members that can solve a lot of issues. And so by solving and reducing the or eliminating the need for travel and reducing time and travel constraints, it can reach far more people. So again, it addresses more of the iceberg piece that in-person care was not and cannot address. So that's the first thing that I want to call out. The second thing that I want to call out is digital care pathways, especially like SWORDS programs, which have asynchronous care pathways built into it, are by nature scalable, whereas in-person care is not. And therefore, what we need to ensure is that the quality of care is still there, because if it is there, and we've proven that it is, I'll get to it in a minute, then automatically we are more scalable than in-person care, which means that we can improve access to evidence-based and high-quality care. Now, the third aspect that I wanted to mention is SWORD has a deep commitment to clinical validation and clinical research, and we have compared all our digital programs against high-intensity in-person physical therapy, the gold standard of care. So we didn't compare our programs against what people usually get. We compare our programs to what people should get in an ideal world. We've done that for recovery after a hip replacement, knee replacement, and shoulder tendon repair surgery. And we are doing that currently, finishing 2 additional clinical trials for chronic shoulder and chronic low back pain. In the trials that we've already completed, we've shown to outperform in-person PT because of 2 things. We can pack a lot more intensity early on, and there is a dimension of empowerment of the person and of the member, which leads to changing behaviors and sustained changing behaviors over time, which helps solidify gains. So this is, to wrap up, virtual reduces barriers to access, is scalable, and if done right, and if it's evidence-based, can be used to maximize engagement, completion, and therefore clinical outcomes in comparison with in-person PT.
And that is why Fernanda's mom is using us for her post-op hip rehab right now. Thanks for...
Actually, while we are talking, my mother is staying with me for these weeks for greater support. I'm on the background, I'm seeing that she's doing another session, so the second session of the day. So I know it's happening. So the next question that I have assigned to me is, does SWORD work with other providers? And how do we work with the members' physicians? So SWORD assigns a PT to any and all members. So our programs are managed by physical therapists, which are healthcare professionals that have always coordinated care with the physicians and with or orthopedic surgeons. So the short answer is yes, we do work with the physicians, and we can exchange information through SWORD 360, which is a bidirectional API which allows us to integrate with more than 19% of existing electronic health records in the US. And we can also and gladly work with brick and mortar providers for members who do need some form of in-person care and or need to transition from in-person care to digital care. And that is all done so circulating information through SWORD 360 and by having our physical therapists in contact with the healthcare professionals taking care of that member.
If you're okay, Fernando, I'll jump in with one that I have
Okay.
in my queue, which is why haven't I heard about using physical therapy for pelvic health issues before? And the sad answer is that there's probably a lot of even clinicians who haven't. And part of that is because our system, as we saw on that slide for Darlene, is fairly disparate. We are in little silos practicing by ourselves, and it takes a long time for clinical research to trickle down into clinical practice, like 7 years or more. So people may not be aware of this to offer it to their patients. Going back to the slide from the quote from Susan Sarandon too, like we kind of are taught to just, that pain is a natural thing that comes along with things like childbirth, and the answer is just to deal with it. And sadly, people don't take a moment to pause and say, like, is that the right answer? So it's really the key thing that we need to bring into pelvic pain and rehab. And one of the reasons why we moved into this area at SWORD is because we know it's a massive gap that we're not serving, and we want to be able to help people with this problem. I'll give it back to you, Fernando, for your next question.
Thank you, Megan. So the next question that I have here is, what are the biggest hurdles that prevent people from using more virtual physical therapy in lieu of surgery? So I would say the first level of answer to this question is we need to increase public knowledge about the impact of physical therapy, which can be delivered in a number of ways, digitally or in person. And a few years ago, when we looked at data for almost 2 million people, we saw that less than half of them were actually prescribed physical therapy. And less than half of those ended up engaging with physical therapy. So one, people don't know that physical therapy is probably the first place they should go if they have an MSK or pelvic issue. So we need to raise awareness on this. And second, they don't know they can access physical therapy directly without going first through their PCP or their orthopedic specialist. And this leads us to one very important partnership that SWORD and the APTA, the American Association of Physical Therapy, have established recently. So SWORD is the first digital MSK care company to partner with the APTA. And we are doing that because the two institutions share the same ethos. And we are collaborating in a number of initiatives. We want to drive the adoption of digital health and digital physical therapy. We want to improve diversity, inclusion, and equity in the space, but we also want to reinforce the message that PT should be the first approach to tackle MSK and pelvic health issues. So the biggest hurdle is people don't know that pelvic health therapy is actually what they should seek, and that physical therapy is the first thing they should seek for MSK issues. The second thing is, obviously, prior to the pandemic, there was a lot of skepticism around digital interventions. Now, much, much less so. Still, there is, in some segments of the population, still a bit of skepticism around the ability to use technology and to deliver interventions through technology that have the same quality, at least the same quality as in-person care. And the only way to bring down this barrier is by doing what SWORD is doing and having a deep commitment to clinical validation, which results in well-designed clinical trials as well as real-world evidence being pushed out there, and showing through robust data that we can improve clinical quality while delivering fully digital programs.
I think that's your comments about the American Physical Therapy Association are a good transition to this question, which is just clarifying, does everyone get a physical therapist? And the answer is yes. So we employ doctors of physical therapy to take every single member through their program. And that's somebody you will select at your onboarding, the person you want to work with. We know that that's important that you work with somebody who relates to you, whose experience or history resonates with you, and that you have a partner throughout your entire journey who's able to do things like screen you to make sure you're appropriate, to direct you to other levels of care, going back to the question about how we work with other providers, if that's necessary, and then to help educate you in a way that provides you with clear understandings of your conditions and how to get better without creating fear, because fear is what drives people to stop moving, to shut it down, to not do the things that are going to help them. And so we need to educate you and make you empowered to manage your health and not scared of your body. Perfect. That's the end of my Q&A queue. Fernando, do you have any other questions to answer?
We have a question about is the pod device applicable to both men and women?
Oh, perfect. Yes, I answered that in chat, and that's a great question. So our Bloom program and the associated pod is designed for people with vaginal anatomy, and it is going to serve then mostly women.
And then I have a question about whether we do address chronic fatigue syndrome. Our current programs are designed to tackle one specific joint at a given time. Still, at this point in time, I would answer solely and a bit vaguely with stay tuned.
Awesome. I just saw a question come in around, from a PT perspective, how are direct access and referral regulations navigated? Well, this is something I know more about than I ever thought I would 2 or 3 years ago prior to joining SWORD. Every state is specifically creates guidelines related to direct access and need for referral. That's a state right, not a federal rule. So we have to look at every single state. And in order to do that, we have a team that thoroughly reviews it, who manages PT licensure, who collects referrals if required for specific states based on their regulations, and manages that all to take it off the member's plate. So we know that that type of navigation is really confusing and burdensome to the individuals who are experiencing pain. So SWORD handles that all internally so that we're compliant with all the state-specific regulations.
There is another question that popped up just now. One of your competitors has a pain relieving device available. Does SWORD have plans to add a similar device to the program? Very interesting question. So one, we focus on long-term pain improvement. And this means exercise and changing the way that people behave and cope with their conditions. This is really what solves the problem for good. So we're not looking at temporary pain relief, we're looking for long-lasting pain relief. And on that quest for long-lasting pain relief, we use evidence-based care. And so what we have to say is that after 150 plus clinical papers and more than 50 systematic reviews, there is no solid evidence that TNS works as a long-standing tool for pain reduction, to the point that Medicare and a lot of other health plans no longer reimburse it as a pain relief technology. So that is why we do not believe in such devices. Finally, we also, and the data that we have shows that the concept of being in too much pain to exercise is unrealistic. When we look at our member base, which has pain levels from 7 to 10 at baseline, they are not less likely to start the program as members with less pain. They are not less likely to complete the program, and they are not less likely to improve. So what this tells us is that being in too much pain to exercise is a theoretical concept that bears no proof in practice, and actually it doubles down on it needs to imply a redoubling of the efforts to get these people to exercise and to engage in CBT programs, because that is what's going to down the line ensure long-lasting results.
Yeah, just getting back to the comment I had about why we use physical therapists and avoiding fear. I think that that's part of it too, is we want to make sure that we're not sending somebody some sort of device that implies that they're broken and need to be fearful of movement. We really want to be getting at them at the beginning and sharing the ways that they can actually manage their pain really quickly. And that's what I went to school for. That's like what we're trained in doing, is teaching people how to use movement to manage pain immediately. And the long term of that and the short term of that are both beneficial. So it's an important question. Thanks for answering it, Fernando.